And now it's my pleasure to introduce Daniel Carlat. Dr. Carlat is a practicing psychiatrist who also serves as an associate clinical professor of psychiatry here at Tufts University and is an active mental health journalist. He is the editor-in-chief of the Carlat Psychiatry Report, a peer-reviewed newsletter on psychopharmacology, and his blog, the Carlat Psychiatry Blog, has received an award for outstanding mental health journalism. And he has also written for Psychology Today, the Psychiatric Times, and the New York Times. His new book, Unhinged, takes aim at his profession and asks the question, is psychiatry fulfilling its essential purpose? While the goal of psychiatry and its related fields ought to be to understand and heal mental illness, Dr. Carlat argues that overemphasis on prescription drugs and de-emphasis of talk therapy have shifted the goal from the simple treatment of symptoms.
Thank you very much for coming out tonight. And as Rachel was talking about all the blogging that I've done, as I was browsing, I saw a book that said, What the Internet Does to Your Brain, and I'm thinking, wow, this is really what the Internet has kind of done, is creating this book, is what the Internet has done to my brain. So I was at I was in New Orleans recently at the APA meeting, the American Psychiatric Association annual meeting, and I got a taste of just how angry it's possible to make some people that are in your field when you are critical. I mean, there's been a lot of books out that have been somewhat critical of psychiatry, and typically they have not been written by psychiatrists. When you're a psychiatrist and you become critical of your field, you're in for kind of special retribution. And so I was walking around the booths, the publishing booths at the APA meeting, and there was a woman who's quite a big wig in the field. She's written textbooks in child psychiatry, and she's used to edit one of the journals in child psychiatry. And I went up to her to introduce myself because I just started a newsletter in child psychiatry. I wanted to just sort of show it to her and see what she thought. So she took one look. I said, hi, I'm Dr. Carlat. Nice to meet you. And she took one look at my name tag and said, oh, I know you. And there was something in her face that was a little bit hostile. So I said, in a good way or a bad way? And she said, well, in a bad way, to tell you the truth. You, in your New York Times article, trash your training at Mass General Hospital, and then you say that you came to this realization that you had to understand your patients. Meanwhile, you're writing these articles in order to sell your books and your newsletters. This is all at high volume with about 20 people waiting at the table. Meanwhile, of course, she's signing her own books. So that was lost on her. Anyway, so I walked away, and one of the women who was waiting in line stopped me and whispered to me, I get your newsletter, I really like it. She was waiting in line too. Anyway, so in the small world anyway of those of my fellow psychiatrists, this type of book and the type of articles that I've written generate a lot of controversy. Because essentially what I'm arguing in this book is that we, as a field, are providing substandard care to our patients, even though there is a hierarchy in psychiatry, just like there's a hierarchy in authors. You know, Sebastian Junger gets paid $5 and he got to go to the Brattle Theater. I'm here for free. But just like there's a hierarchy there, in psychiatry there's a hierarchy. You have the psychiatrists who prescribe the medications. For those who don't know the difference between a psychiatrist and a psychologist, psychiatrists are the ones that go to medical school and prescribe the medications, and the psychologists are the ones that go to psychology graduate school and are not able to prescribe medications. So for years now, people in my field have developed something of an elitist attitude vis-a-vis those who are in other fields, who are the therapists. And that kind of attitude is something that I think I absorbed by osmosis while I went to do my residency. I did my residency nearby here at Mass General for psychiatry. I did medical school in San Francisco. But it was something that I kind of absorbed by osmosis, having started my residency in 1992, which was shortly after Prozac came on the scene. And this was a time when the medications were coming out at a dizzying clip. And there was a sense in which we had finally gotten it. And there was a sense in which, as psychiatrists, what we could do is just prescribe the medications because we had understood the biochemistry of the brain. And for those messy issues that people have to deal with that could not be dealt with medications, we could just refer them to people like social workers and psychologists. So there was a sense in which, aren't we lucky that now that we have been able to figure out the biochemistry, we don't have to do that stuff anymore. So this was sort of the culture that I was trained in. And it's a culture that I think a lot of people, as a lot of psychiatrists actually, are thinking twice about these days. And the article in the New York Times Magazine that was sort of prelude to this book was called Mind Over Meds. And it was basically an article saying, you know, psychiatrists prescribe too many meds and we don't do enough therapy. And it was really uncontroversial, surprisingly so. And many psychiatrists, which was surprising to me, wrote me, emailed me, or left comments on the New York Times website saying, essentially, bravo, I agree with you. In fact, I'm one of the psychiatrists that still do a lot of therapy. And there may be some in this audience that do, and there are many psychiatrists out there that still are able to do plenty of therapy in their practice. But the latest figures, these were from about 2005, were that only 29% of all psychiatry visits entail psychotherapy, and only 11% of all psychiatrists offer therapy to all their patients. So something has happened over the past several years in which we have given up therapy and we're doing mostly medications. But let me read a bit from just chapter 1 of the book, which I read from mostly because if there was sort of an awakening that I had in my gradual shift from being a psychopharmacologist, which is the type of doctor that prescribes meds, to becoming more of an integrative practitioner, this woman, Carol, was the type of patient that helped me to shift my way of thinking. So chapter 1 is called The Trouble with Psychiatry. For the last 15 years, I practiced psychiatry in a small town north of Boston, Newburyport, actually. It is a solo private practice. I see mostly middle-class patients who come to me with depression, anxiety, substance abuse, and occasionally more severe problems, such as bipolar disorder or schizophrenia. Like most psychiatrists in my generation, I've specialized in prescribing medications and have referred patients in need of talk treatment to a psychotherapist. During my training at Mass General, I was taught that we were on the threshold of understanding the biochemistry of mental illness. And I'll also say that the 1990s were the decade of the brain, so there was this feeling at NIMH, too, that we were about to kind of unlock all the secrets. After I graduated from residency, I worked hard to keep up with the explosion of neuroscience knowledge, absorbed the intricacies of how to use the new drugs as they poured forth from the drug companies. By harnessing these powerful meds, I thought I was providing my patients with the best psychiatric treatment possible. But a couple of years ago, I saw a patient who made me question both my profession and my career. So Carol, in her mid-30s, had short brown hair and strikingly green eyes, I'll always remember, that were filled with despair. Once we were seated in my office, I asked her, "How can I be of help?" "My father was killed in a car accident," she said, choking back tears. "How awful," I said. "When did this happen?" "Last month." Carol told me that she had been in the car with her father, who was driving. They came over a rise in the road, and another car was just pulling out of a driveway in front of them. Her father tried to swerve, but it was too late. They collided with the other car, and her father, who was not wearing a seatbelt, was killed instantly. And miraculously, Carol was not seriously injured. Since then, she told me she had recurrent dreams about the accident and couldn't prevent herself from replaying the scene throughout the day over and over again. The events would unreel themselves like a movie in front of her, and often she would start sobbing uncontrollably. These were typical symptoms of post-traumatic stress disorder. She said that she experienced, I asked her a series of questions, she experienced these symptoms. She said her life was constricting inward. She said she drove rarely, avoiding especially the road where the accident had occurred. "Are you avoiding anything else?" I asked. I won't watch TV. I can't read the newspaper. I never realized how many stories there are about car accidents in the news. I asked her about symptoms of depression, and she reported that she had some. She had insomnia, poor motivation, but luckily no suicidal ideation. The worst thing, she said, is how guilty I feel. Why guilty, I asked. It was my fault that we crashed. I got him upset. Her eyes began to well up. I was telling him that he shouldn't be drinking. He was drinking and driving? She nodded. I told him I could smell it on his breath and that he shouldn't be driving. He got mad, started yelling at me, and then he floored the gas pedal, said something like, "Am I driving good enough now?" And that's when it happened. I could see that this was going to be more than just a simple case of PTSD, if there really are such cases that are simple anyway. She would have complicated feelings about her father to wrestle with, grief, regret, and eventually a good deal of anger. I then told her that I thought she had PTSD. I wrote out her a couple of prescriptions of medications, Zoloft, which is a Prozac-like drug, a serotonin reuptake inhibitor, and the tranquilizer Klonopin. And then I reached in my file cabinet and handed her a business card. And this is a good therapist who I often work with, I told her. I recommend that you give her a call and set up an appointment. The medication works better when you're also seeing a counselor. She looked confused. Aren't you my therapist? I shook my head. Unfortunately, I don't have time in my practice to do the therapy. I usually refer my patients to a psychotherapist I can trust here in the community. So, am I going to see you again? Yes, I said, we'll schedule another appointment in about a month to see how the medications are working. But in the meantime, I hope you'll have had a couple of sessions with this other doctor. Carol still didn't look at all happy about this. But aren't there any psychiatrists that do therapy, she said. There are a few, I said, but not many. They're hard to find these days. So Carol left my office, and after she left, I finished writing her note. I closed my chart, put my pen down, and looked out my office window at those white-steepled Unitarian church that's right across the street. And there was nothing really unusual about my encounter with her as I was reflecting. This is a few years ago. I did what most psychiatrists do when they encounter a new patient. I sat comfortably in my red leather chair, wearing my suit and tie. I asked her a series of diagnostic questions. Her answers fit neatly into a recipe book of psychiatric diagnosis called the DSM-4, which is our list of mental disorders. I pieced together a diagnosis that made sense to me. I then reached over to my desk, wrote out a prescription, and handed this to her. Pondering this typical appointment, what struck me most was what I did not do. I am an MD, and it really was not fun going to medical school, I can tell you. Basically, medical school is 12 years of training when you include the pre-med courses in college. So I did my grueling medical internship in a general hospital, my 3 years of psych residency at Mass General. But like most psychiatrists, I did little to take advantage of those years of training. I did not do a physical exam, nor did I take Carol's pulse or blood pressure. Typically what we do in psychiatry is we get the patient's primary care doctor's records to establish that they don't have a physical cause to their distress. Indeed, the only times that I stirred from my chair were to meet her in the waiting room at the beginning and to show her into my secretary's office to make a follow-up appointment at the end. Just as striking to me as the lack of typical doctorly activities in psychiatry is the dearth of psychotherapy. Most people are under the misconception that an appointment with a psychiatrist will involve counseling, probing questions, and digging into the psychological meanings of one's distress. And my sense is that probably here in Cambridge, that's not so far from the truth. It's probably fairly easy to find a psychiatrist here who does do more therapy, but it's not only is it hard to find that type of psychiatrist in most other places, it's hard to find a psychiatrist at all. It's usually a 3 to 5 month waiting list if you can find someone. But the psychiatrist or psychotherapist is an endangered species. In fact, according to the data from Columbia University, as I mentioned, only 1 out of 10 psychiatrists offers therapy to all their patients. doing psychotherapy doesn't pay well enough. I can see 3 or 4 patients per hour if I focus on medication. Such psychiatrists are called psychopharmacologists, but only 1 patient in that time period if I do therapy. And that income differential is a powerful incentive to drop therapy from our repertoire of skills, and psychiatrists have generally followed the money. While Carol's case was dramatic and quite tragic, her treatment, I found, was not particularly dramatic in the sense that her story illustrated a kind of a typical treatment approach for modern-day psychiatry. And her story illustrated for me both the triumphs and the failures of modern psychiatry. So that over the last 30 years, we've constructed a reliable system for diagnosing mental disorders. And we have created medications that work well to treat a range of psychological symptoms. But these very successes have had unpredictable consequences. As psychiatrists have become enthralled with diagnosis and medication, we've given up the essence of our profession, which is understanding the mind. We have become obsessed with psychopharmacology and its endless process of tinkering with medications, adjusting dosages, and piling on more medications to treat the side effects of the drugs we started with. We've convinced ourselves that we have developed cures for mental illnesses like Carol's, when in fact we know so little about the underlying neurobiology of their causes that our treatments are often a series of trial and errors. So that was one of a series of patients, as I look back on the last 5 years or so, who taught me something about what I felt I was doing wrong. And in this case, I thought to myself, after the 12 years of training that I have, what do I really have to show for it as a psychiatrist? Essentially, what I do day to day is I prescribe medications. That's not me. Good. I prescribe medications. I write out prescriptions. And when I have a patient like Carol, who may or may not benefit from one of the medications, and actually post-traumatic stress disorder is unfortunately one of those conditions that doesn't necessarily benefit very well from medications and benefits very well from psychotherapy, I can't do it. So 12 years of schooling and I can't do some basic therapy techniques. One of the pieces of feedback that I've gotten from some psychiatrists who have been critical of the book and of my thesis is that you're selling yourself too short, and psychiatrists actually do therapy. And it really depends on what you mean by psychotherapy. If you mean a 15-minute appointment where you prescribe a medication and give some words of advice, and if you call that therapy, then yes, maybe we are doing therapy. But there actually are very specific psychotherapeutic techniques like cognitive behavior therapy or psychoanalytic therapy, I was just writing about mindfulness-based therapy, which are specific techniques that can be used to treat specific illnesses. And typically what happens is that I will see a patient who has, say, panic disorder. There are very good medications to treat panic disorder, but typically patients will only get about 50% of the way better. And then the cognitive behavior treatments that are required to get them all the way better are not in my repertoire, and they're very hard to find. It's actually very hard to find anybody that can do that kind of treatment. So that was sort of the awakening that I began with, that I began the book with, and then I go through, and in the rest of the book, I sort of ask, how did we get to this point? How did we get to the point where we, as a field, have become so fixated on medications? And there are many different answers to that. One of them is simply consumers. Consumers come in, consumers hear that these medications work very well often, and they want them. And if you've ever taken an antidepressant and you've benefited from it, you'll know that you probably can't believe how much better you felt, how much less irritable you were maybe to your kids after you've been on it, if you're one of the lucky people that responds. And then you might tell someone else, and then they'll come to a psychiatrist and try to get on it. But these meds may work for 60 or 70% of patients to a certain degree, but they need more than that, and medications don't do a good job of solving basic life problems. So another piece of the puzzle is, of course, the insurance companies and the incentives to see more patients in an hour. But then another, big piece of the puzzle, and something that I know about because I used to do a fair amount of speaking for the drug companies, is the effect of the pharmaceutical industry. And for a year in 2002, I spoke for Wyeth Pharmaceuticals, pushing Effexor, which is one of the antidepressants. And I learned about how sophisticated some of the techniques are, not only for getting you as consumers to come to your doctor after seeing a commercial for Abilify or Seroquel and asking for it, right? But even more so, how drug reps are able to come to doctors' offices and convince us that they have the next big drug. And I will, let's see, how much time do I have? Yeah, I have a little bit of time left to talk a little bit about some of the techniques that the companies have used over the last several years. And I'm happy to say that we now are understanding some of these techniques and that there is some legislation in place that's going to curb some of these abuses. But in Chapter 5, How Companies Sell Psychiatrists on Their Drugs, I talk about Neurontin, which is a drug some of you may have heard of. Neurontin was a drug that when I went to New York City, when Wyeth flied my wife and I to New York City to go to what they called a faculty development conference, which was basically an indoctrination for about 100 psychiatrists, where they flew in the best and the brightest psychiatrists to teach us about Effexor, their drug. They gave my wife and I Broadway tickets, and then at the end of the conference, I got an envelope with $1,000 check just for being such a good person. So, and then I went off and did a series of drug talks over the next year until I got sick of it. But so Neurontin was this medication that was originally approved for the treatment of epilepsy. And it was really just a very specific drug for the treatment of adjunctive use in epilepsy that wasn't adequately treated with other drugs. And the company that made it, Warner Lambert, later bought out by Pfizer, estimated that they could make about $500 million over the drug's patented lifetime. And a patented lifetime is 20 years, but it's usually about 10 years after they've gotten through the FDA process. So $500 million may seem like, and here I'm reading, may seem like good money to you and me, but it is positively mediocre for drug companies, which define very successful drugs as those bringing in $1 billion or more in sales per year. We're not talking over the patented lifetime, per year. $1 billion here, $1 billion there, and you're starting to talk about real money eventually. And the companies, the kind of startling statistic that's a little outdated now was that the top 10 drug companies in the Fortune 500 list of companies made more in profit than all 500 other companies in the Fortune 500 combined. And I think they've been surpassed by maybe banks, but now they're probably ahead of banks again after what's happened. But at any rate, the executives didn't like the idea of only having to make $500 million over the course of the patented lifetime, so they came up with a new marketing plan. They had found that a small number of studies, a case series, had shown that Neurontin might be effective for several other conditions, such as bipolar disorder, migraine headaches, neuropathic pain, and ADHD. And it was often used for things like, many of my colleagues, and I, in fact, used it often for sleep and for bipolar disorder based on these small studies. The evidence was poor, and it did not meet the FDA's criteria for proof of effectiveness. And maybe in the question of answer, we'll find out that the FDA's bar for proof of effectiveness is one of the lowest bars you could imagine. But the executives decided to try to convince doctors to prescribe it for these disorders anyway. After all, doctors are free to prescribe medications for anything they want, even if there's no official indication. And this is called off-label prescribing. Nothing wrong with it. Most doctors do it all the time. Warner Lambert was well aware, however, that it is illegal for drug companies to explicitly market their drugs for off-label uses. Nonetheless, according to a series of stories written by New York Times journalist Melody Peterson, such legal technicalities didn't seem to bother this ethically challenged company. Peterson interviewed David Franklin, who was a former Warner Lambert employee turned whistleblower, who detailed his former company's systematic off-label marketing campaign. Franklin recounted a meeting at which John Ford, a senior executive, exhorted reps to pitch Neurontin to doctors for a long list of disorders, none of them adequately researched. Quote, according to the executive, "That's where we need to be, holding their hand and whispering in their ear." He's talking now about the drug reps talking to the doctors. Ford said, referring to the doctors, "Neurontin for pain, Neurontin for monotherapy, Neurontin for bipolar, Neurontin for everything." He went further, encouraging reps to get doctors to ramp the dose up higher than the FDA's recommended maximum of 1,800 milligrams per day. "I don't want to hear that safety crap either," he said. "Have you tried Neurontin?" He's talking to the drug reps now. "Every one of you should take one just to see that there's nothing. It's a great drug." Warner Lambert kept pushing the envelope of ethics to the point that it was eventually torn to shreds. According to Peterson's reporting, drug reps were explicitly instructed to not leave a paper trail. According to one of the executives, anything you write down can be audited, so don't write anything down. But they were sued anyway because of David Franklin. The company rewarded doctors who were prescribing high amounts of Neurontin with free trips, dinners, or cash, essentially bribing doctors to use more of the drug. The company hired marketing firms to ghostwrite articles pushing Neurontin. And by ghostwriting, basically this meant that the company had hired a writing firm, a medical writing firm, and then the medical writers wrote up the articles, and then they would hire doctors for about $1,000 to put their names on it to make them seem legitimate, and then that way they could get them into the top journals, and then psychiatrists like I would be able to read them, believe that it was written by an academic when in fact it was written by the company, and then I would prescribe more Neurontin. For example, one memo from this marketing firm read, quote, "Draft completed, we just need an author," unquote. Minor detail, right? The company paid doctors to allow reps to read patient charts and to shadow doctors during visits. In some cases, reps convinced doctors to prescribe Neurontin for off-label uses during these so-called preceptorships. These sleazy techniques worked beautifully. The drug became a blockbuster, earning $2.7 billion in 2003 alone. Almost all of that income was from off-label uses. In 2004, experts estimated that 90% of Neurontin prescriptions were for disorders not approved by the FDA. Eventually, due partly to David Franklin's revelations, Pfizer, which had since bought Warner Lambert, pleaded guilty to criminal charges and agreed to pay $430 million in fines, which was a pittance in comparison with the billions the drug was earning per year. So for Pfizer, it was simply another business expense, and a fairly minor one at that. So you can see that with the ways that the companies are slapped on the wrist, essentially a $400 million fine amounts to the amount of money that a company might make in a week or two, so that it doesn't really do anything to prevent these practices from occurring. And since Neurontin, some of you may have been reading papers. I mean, these stories are starting to come out a lot. Zyprexa Lilly has paid a $1.3 billion fine to settle allegations of off-label marketing of Zyprexa, which is an antipsychotic that causes 1 pound of weight gain per week in many of my patients anyway, so that you have a normal person sort of starting the medication and then they balloon up over the next couple of months, and it can also cause diabetes. So the process here of us becoming largely pill pushers is a complicated one, right? It's not just one thing. It's not just that the evil drug companies are causing us to prescribe drugs. It's not just that the insurance companies are messing up our reimbursement. It's not just that the patients are coming to us. It also relates to something within our profession. And when I think about my training and the people that trained me, I remember that we were very, very proud to be MDs. And part of the issue here is that the only way that we can really prove to ourselves that we went to medical school is by prescribing a medication. And the other chapter in the book where I talk about some of these talismans of MD-hood is where I talk in a chapter called The Seductions of Technology, where I talk about a very successful treatment called ECT, which actually former Governor Michael Dukakis' wife, Kitty Dukakis, had, and she responded to wonderfully. She wrote, with Larry Tye, a book called Shock. And after, it's not often that you get an email from Michael Dukakis, but I got an email from Michael Dukakis after having written the New York Times article, Mind Over Meds. And he was concerned, actually, that I not say so many, quote, bad things about the biological option that I steer people away from certain things that worked. And I've seen Michael and I've seen Kitty speak, and their story is very, very poignant. So some of these things work, but the new machines, such as vagus nerve stimulation or transcranial magnetic stimulation, have been approved by the FDA with very, very little evidence that they actually work. And in some cases, these machines that are sometimes implanted, other times are simply like a big dental chair on steroids, like the magnetic stimulation therapy, really don't work any better or not demonstrably better than placebo. How am I doing here? Should we stop kind of for questions, or getting pretty close? Okay. Well, let me open it up for questions now, and we can kind of go through and talk about some of the other issues. For example, one of the issues that I haven't touched on here is a chapter called A Frenzy of Diagnosis, which gets into the whole DSM and the Bible of psychiatry, which at the New Orleans meeting was interesting because I went to a presentation where a psychiatrist, actually I think she's at McLean, Kathleen Phillips, has come up with a new diagnosis called olfactory reference syndrome, which is a diagnosis of people who believe they smell terribly, believe they have terrible body odor, or they have terrible mouth odor, bad breath, but they actually don't. And so she was able to find a case study of about 20 people who suffered this problem, and she presented data to show that these people suffered terribly and they became suicidal at times because their problem was so bad. And we were joking that the worst problem is people that don't know that they smell but actually do smell. Maybe that should be a DSM diagnosis. But I think, and I think that there really are, I'm sure, people that have olfactory reference syndrome and do suffer. But I think this points to the reality that psychiatry is a funny field where, since we don't have objective criteria, we don't have a blood test, we don't have x-rays to make our diagnoses, we use these symptoms, and we can kind of corral and mix and match certain symptoms in different ways in order to create these labels. And the DSM, which is our list of disorders, has gone from about 180 different diagnoses in 1968 to roughly around 400 disorders with the next edition, which is DSM-5, which will come out in 2013. Yeah, I mean, and anybody here who is a psychiatrist or who knows someone who is and has heard about the training will know that, in fact, in all psychiatric programs, there is a large psychotherapy component. And what that typically means is that you are really thrown in to the room. It's like kind of like being thrown into a lion's den is how it feels when you're first doing therapy, because you have no idea what to say. You're basically thrown into a room with the patient. You wallow around a bit and you try to be as helpful as you can, and then you leave and you talk to a supervisor and you learn that way. It certainly happened. They did a lot of that at Mass General, which is kind of ironic that I was yelled at for trashing Mass General about not teaching therapy, because in fact they did a pretty good job of teaching therapy. But the problem is, like any skill, and probably more so therapy than almost any skill I know, it takes a lifetime to master. And so that the typical psychiatrist will leave a program like that, will have learned the relatively easy skill of prescribing medications, and then will do mostly that for the rest of their career. And if you don't devote a certain large amount of your time in your practice to doing therapy with patients, you just ain't going to learn it. You'll never be good at it. So, right, yeah, and that's an interesting. Yeah, it was an article in the New York Times, and it's also a book. It was based on a book. Which does anybody know the name? Do you know the name? Crazy Like Us. Yeah. Yeah, I haven't read the book, but I know the Times article was excellent. But yeah, there are certain diseases that are either much more common in the United States than they are in other countries, or they're treated very differently, and the outcomes of the diseases are very different in other countries. Anorexia is one of them. But then what happens is that as the the exportation is not just exportation of a disease, there's an exportation of scientific expertise to other countries as well. So as the psychiatric epidemiologists, epidemiology being the study of the prevalence of disease, sort of get their hands on these other countries, I've been seeing, they've been able to produce research showing that the rates of some disorders apparently are the same in other countries. For example, there's a 1%, an often cited 1% prevalence rate of schizophrenia, and you can get your hands on studies in many different countries where you'll see that it looks real. It looks like there is a 1% prevalence of schizophrenia, implying that maybe it's a biological disorder. And the same is true of ADHD, attention deficit hyperactivity disorder. Sort of that's the kind of one of the defining disorders of apparently kind of a manufactured disorder of a frenetic American society, right? I mean, this is where everybody comes into my office and says they can't concentrate, and they want to be diagnosed with ADHD because they can get speed, which is the treatment for ADHD, to be quite frank. But even ADHD, which early research had indicated was much more common in the United States and other countries, now I'm starting to see some research showing that possibly it isn't any more common in the United States. Again, hard to know sometimes who you can trust, because some of the researchers doing some psychiatric studies are funded by the pharmaceutical industry. Being funded by companies doesn't mean that you're going to lie about your research, but it does mean that you're sort of being selected out by the pharmaceutical industry because you're that type of person who happens to believe in their syndrome, and you're the kind of person, the kind of man or woman who's going to do the research that's going to be sort of most convenient for the company. So the statistics are again a little hard to be certain of, but there was a study done by a group at the Mass General Institute of Health Professions, Eric Campbell led it, showing that the sensational part of the statistic was that, quote, 90% of physicians take something from drug companies, but it turned out that most of that was free samples, and that doesn't really qualify because I still take free samples, and a lot of people take free samples, and because we think it's probably good for a lot of our medication for our patients who are poor. But the more telling statistic was that 25% of all physicians participated in some way in the marketing of drugs. And that was not just speaking for pharmaceutical companies. Some of that was doing what are called phase 4 clinical trials, which are not real scientific clinical trials, but they're just kind of ways of doing research to increase sales of a drug. So there's a lot of physicians out there that do choose to do it, and there's a lot of physicians who choose not to do it. And the question of, it's a very thorny question of psychologically how to differentiate the two. When I go to the APA meetings, and I used to be on the APA assembly, which is sort of the governing body, I would find so many of my colleagues who were livid that I would suggest that they could possibly be influenced by thousands of dollars that they were being paid. Absolutely livid, and you laugh, but these are people who really, really believe that they are invulnerable to marketing, and many of them believe that they're doing a great service to the profession, actually, because it's a win-win proposition. It's they make a lot of money, the drug company makes money through more sales, and the doctors that they're educating get education, and maybe it's 4 wins, maybe the patients win too. So there's a lot of ways of rationalizing any kind of behavior. In my opinion, it is behavior unbecoming of someone in the medical profession to become a paid marketing rep, essentially, for a company. That's not what our patients want us to be doing, and yet rationalization lives on. That's all I can say. It varies about $300 an hour for 3 or 4 medication visits, and maybe $150 an hour for therapy, more or less. So you're going to make about half as much money. And this is kind of fades into the issue of direct-to-consumer advertising, I personally am ambivalent about it, because I think there are some patients who have come to me after having seen a commercial about depression or anxiety, who really never knew that what they had was a condition, could be treated, and come in and get some treatment and feel better. All right. On the other hand, there are many others who come in asking for a specific medication that they probably should not be on, and then I have to have a whole discussion about why that's actually the wrong medication for you, as in Abilify being apparently now a medication for depression, but it's an antipsychotic medication, originally for schizophrenia, right, and bipolar disorder. So it's a tough issue. But I would say, and I'm not slandering anyone, but I would say that you should be careful of WebMD, because, like any medical website, they have to support themselves with advertising, and there's no problem with that. But they go a little bit beyond that, and they allow drug companies to actually rent entire resource areas of their site, so that, like the ADHD resource area might be rented out or paid by Shire. I don't know if that's true, just as an example. And that's where the line between editorial and marketing really starts to blur badly. Right. So yeah, the question is that there apparently are some people who develop emotional problems triggered by events, and others who just seem to come in without any trigger, and maybe it is a chemical imbalance, or who knows what it is, right? And so in my experience in my own practice, I'd say that there's maybe 30% or so of people to whom I prescribe a medication, and they just get better. And it's almost miraculous for that 30%. One patient said it's like when he takes his Zoloft or whatever it is every morning, it's like he's bowing at the altar. I mean, literally is how he put it. It was like a sacred event, because it helped him so much. But the rest of the patients may get a little bit better with meds, and they may not. And it's very, very hard to know what to do in those cases. And I think that's the way that the training of psychiatrists has done such a disservice to patients. Because what happens is that we are so focused on the biological diagnosis, the notion that these illnesses are essentially biological illnesses, that when we are evaluating people who are on that kind of nether zone where is this biological? Is this due to an event? Does this person need meds? Does this person need therapy? Psychiatrists are utterly unequipped to be able to make those kinds of decisions, because we're not trained to make those decisions. And psychologists are also fairly unequipped to make those decisions, because they haven't learned about how to prescribe medications. So what we have is this crazy fragmented system of mental health where we don't have the sweet spot. We don't have the right practitioner who really knows the medications and who really knows the therapy, and who can therefore make those judgments that really take up most of my time, those subtle judgments of how much is environmental and how much is biological. Well, direct-to-consumer advertising is unique to, I believe, 2 countries, the United States, and it's either New Zealand or Australia, or maybe I keep turning to one of my experts here. Is it New Zealand? Do you know, Robert? Australia? I think there's two countries that allow commercials like that, the U.S. and Australia. But there's commercialism in different ways, in many different ways, in many countries, and where in countries that don't allow drug companies to advertise may have much looser laws regarding marketing on the part of the pharmaceutical industry. For example, in many Asian countries, the laws are much looser. So either way, they kind of get you with the commercialism part of it. And it's a good point, and there are many institutions like Kaiser in California that have that model where basically it's a salary model where they pay physicians a salary. And so that the idea there is that you don't have an incentive to squeeze more and more patients into an hour because you're going to get paid the same amount per hour anyway. And therefore the incentive is going to be to provide excellent care to patients. So this is definitely one of the models that was discussed, I think, even in some speeches by President Obama, actually, as one of the solutions to the country's healthcare crisis. I think in psychiatry, that is probably likely to be helpful, but that won't really address the culture of the medical model having kind of taken over the psychiatric mind. So I have, but the trials and tribulations I've gone through in changing it, I think, speak to how difficult our system is set up for other psychiatrists to change their models. So when you start out seeing a psychopharmacology practice, you quickly build up a lot of patients. So I probably have 500 to 1,000 patients that I am responsible for. And so I've gradually changed my system where I'm seeing more 45, used to be a 50-minute hour, it's now a 45-minute hour, so it keeps shrinking. So I'm seeing more patients in the 45-minute sessions, and I'm also, rather than seeing 15 or 20-minute sessions, I'm seeing 2 med patients in a 45-minute time period, which that few extra minutes actually does help in understanding them. But if I do that too much, I'm going to have to kick patients out of my practice. So I'm stuck, and a lot of other psychiatrists, I think, are in the same situation where it is tough to transition from a psychopharm kind of practice to a more integrative practice. Yeah, so there are certainly some psychiatrists that do ascribe to certain kinds of theories of therapy. I'd say the majority of them these days would say that they're quote eclectic. Eclectic is the term used, where they would say that they pick and choose from whatever the technique they think is most effective. Yeah, I do. I mean, I think that the average kind of therapy done by most psychiatrists is eclectic, maybe verging a little bit more on the Freudian, which is now termed psychodynamic instead of Freudian. But and then as far as the MRI question, mostly that's charlatanism. And I have in my chapter on the seductions of technology, I talk about Daniel Amen, who's I think a very good psychiatrist, a very good writer. He has several books, best-selling books, right in this bookstore. And I once did an article for Wired magazine where I submitted myself to some of his brain scans to see if they worked, and I felt that they were basically the information that you could derive from such scans was valueless, in my opinion. And obviously he has a different opinion. We're all entitled to our opinions. So, well, one of the things that I recommend for the field as a whole is to think seriously about physician extenders and psychiatrist extenders. So just as we had a whole series of turf wars around nurse practitioners and primary care doctors in the 1960s, and now probably most people in this room see a nurse practitioner. I know I do typically when I go see my doctor, and she does a great job. It's usually a she. I think that the next frontier in that is going to be psychologists seeking prescriptive authority, prescriptive privileges, which they already have in all branches of the military and New Mexico and Louisiana, and it's kind of a state-by-state thing. And so for my money, that's really the ideal mental health practitioner, because that's somebody who has trained basically in what we do day to day, which is psychology. That's mostly what I do. Is I'm having mind-to-mind contact with people, trying to understand them, and then they would have an extra couple of years of psychopharm master's training to be able to prescribe the basic medications. So that would be that would be the ideal. But it's very controversial. Most psychiatrists would disagree with that. Kind of the central question of the really of this entire talk, I think, in some ways, is how did we move into the drug culture, and how can we kind of get away from it in a way that doesn't say no to all drugs, because some of them work for some people, right? And again, it's a question of culture. I mean, if I am trained in a medical culture that is a medical model, chances are not very good that I'm going to be reading a lot about diet and exercise, and it's going to take something for me to have an incentive to start doing that. It's going to take research, and the research money isn't there because no one can really patent exercise, for example. But I think the overall point is that we do, I believe, over-medicate people in general, and that we haven't tried another strategy, which is to try to wean people either off of medications or just to take them down from 5 to 4, from 4 to 2 or whatever, or from 1 to a lower dose, because we're not trained to do that. And I think that really the entire training system would need to be revamped for that to happen. So your point is well taken.
Thank you.
Thank you.